Thank you so much for being here with us today. Can I ask, who here has been to one of our events that we've had for Seniors Week before? Excellent, and you've come back for more, so we're doing something right. It's excellent to see you all here again, and welcome. This is a fantastic initiative that's been put together by Council on the Ageing and Sydney Mechanics School of Arts, and we're very fortunate to have two experts here with us today to help us navigate that often elusive journey of healthcare. To start off, we have Dr. Anthony Brown, CEO of Health Consumers New South Wales. Anthony will be giving the keynote address and will then join us for the panel discussion as well. Anthony is an expert with over 12 years' experience in the health and community sectors. He holds a PhD, which is focused on men's health, and his work is across men's health, older people, and retirement. Dr. Brown is also an honorary chair of the Global Action on Men's Health, where he advocates for better health choices and consumer involvement. We'll also be joined by Dr. Kim Loo for the panel discussion. Dr. Kim absolutely encapsulates everything that is advocacy. She's a fierce advocate for her patients. She's a fierce advocate for the community when it comes to issues like sustainability and climate change. And we're very pleased to have her and very fortunate to have her with us today. Dr. Loo is a GP and she's got 36 years experience within Western Sydney, and she's here today representing the Royal Australian College of General Practitioners, which represents some 40,000 GPs. So without any further ado, please join me in welcoming Anthony to the stage.
Okay. So where's my little clicker? All right, thank you so much, Gohar. And before I start, there's two things I want to do. Of course, I also acknowledge the Gadigal people and pay respects to elders. But I also want to acknowledge and thank everybody, and I expect there's a few people in this room who are involved in working to make health systems and services for older people better. We really believe at Health Consumers New South Wales that if you want to make healthcare better, you need to talk to and involve patients and carers. Wow, radical. And I know there's people in this room who are involved in that work, and whether it's with healthcare or aged care or any other sort of service, I just want to thank you, because we won't make the system better until the people who are using the system are actively involved in designing and running it. So before this morning, who's heard of Health Consumers New South Wales? Okay, good smattering. Okay, is anybody a member of Health Consumers New South Wales? Okay, good. We're giving out free memberships at the end. But memberships are free anyway, so. So what we do, so as I said in that, when I thanked people, we really believe that health services are better when the people who use them, when patients and carers and families are actively involved in designing them, are actively involved in running them, and are helping to do the same things with health policy and health research. And that's why we exist, to make that happen. Now, I'm going to use this term health consumers, and I know people don't like the term. Some people love it, some people hate it. And I'm going to slip into using that term throughout my talk. And when I use that, what I mean are the people who use or have used or are potential users of health services. And including families and carers. Now, not all carers like that definition, because we are grouping patients and carers together here. And there's a couple of reasons why we use that term, because we're not patients all the time. We're patients when we're in front of a doctor or when we're in the hospital, but then we're living our lives and dealing with health issues and our recovery or the results of treatment. And also, when people in the 90s started to use this term, they really wanted to link that idea of being a health consumer with the idea of consumer rights. So we know if we go and buy a TV that doesn't work, we have certain rights under law about replacements, getting it fixed, guarantees, that sort of thing. And so the people who started to use that term really wanted to link it to the idea of rights. Other people nowadays are saying, oh, it's too closely linked to the idea of a market and us being sort of, members of a market. But that's where it comes from, and that's what I intend when I'm using it. So one of the things that I want to highlight is that idea of rights is something that's really important and, in theory, is at the heart of what healthcare should be. Now, this is, I think, one of the most important documents about healthcare that we've got out there. The Australian Charter of Healthcare Rights. Now, Australia doesn't have a Bill of Rights, but we have this charter, which is something that's been signed off by all governments, by the Australian government and New South Wales and the other state governments. So before today, how many people here knew that we had this? Okay, 3. So this should be on display in all hospitals. This should be given to people when they come into hospitals as inpatients. And I'm seeing increasingly a number of GPs are putting this up. But this is at the heart of our healthcare. Now, I'm not going to go through all of this today. That's another talk. But and what I want to concentrate today is really on this right to information and the right to good quality information and what we can do to make sure that we've got good quality information and that we're using that. But I'm going to provide some links at the end, and there'll be links on the CODA webpage when this comes out, and people can find out more about healthcare rights. Now, the other word that we've used a bit, and we'll hear a few times through the talk today, is the word advocacy, which means different things to different people, different things in different contexts. So I wanted to just quickly introduce people to the idea of advocacy and what I see as the 3 types of advocacy. Other people say there's 5 types of advocacy, 7 or whatever. Let's stick to 3. And so I'd like to talk about self-advocacy. And that's when I speak for myself. I might be in front of my GP or at a doctor's or somewhere else, and I'm talking about what's going on for me and making choices about me. And so when I'm a self-advocate, I'm speaking for myself and saying this is what I want and this is what I need. People then also talk about individual advocacy, and that's when I speak on behalf of another person. So in a healthcare context, that might be a parent speaking on behalf of a child, or it might be an adult child speaking on behalf of a parent with dementia or cognitive issues, or it might be somebody who's an enduring guardian, whose guardianship, who's speaking on behalf of somebody who, for whatever reason, can't speak for themselves. So that's about where I have responsibility to speak on behalf and make decisions on behalf of somebody else, and I'm doing my best to make sure they get the best care and the care we think they'd want. And then there's systems advocacy, and that's when I work with other people to create better systems and services. So today I really want to give people some tools that I hope will help with both self-advocacy and individual advocacy, because I know most people in the room, there's times when you have or are talking on behalf of somebody else, but also give some tools to hopefully help with your own healthcare and make things better. At the very end, I'm going to talk very briefly about systems advocacy and ways that we can get involved in making the whole system better, but that's not the focus of today's talk. So what I'm going to concentrate on today are 2 things. Talking about questions, and the questions we can talk to and ask when we're talking to a doctor or a health provider, whether that's a GP or in hospital or whatever. So we have the right to ask questions about our care. I want to go through that. And then I want to briefly talk about where we can go to find out good information. There's lots of other things that people can do to make your health journey better and give you more advocacy and more autonomy in what you do, and I'll leave people with some resources about that at the end. So this is some work that was put together by the Choosing Wisely group. And Choosing Wisely was a group of practitioners, people from government, health consumers who came together to say, what's the information, what can we do to help make better decisions about healthcare? Because one of the things, and this doesn't seem obvious at first, but if we are better and if we are more informed about getting the healthcare that we need, not only does that help us and give us better health outcomes, it's also actually better for the health system, and it saves the health system a lot of time and a lot of money. Because if we get what we need the first time around, then we don't have to go back for follow-up appointments. Hopefully there's less complications, and the healthcare system doesn't have to then spend money fixing up what they could have fixed at the start. So lots of people are interested in getting those first visits right. And they came up with these 5 questions as a suggestion that people can ask before we get any test or treatment or procedure, and I think they're useful when we're discussing our care. Now, I'm not going to go into them in detail, but that idea of asking first off, do I really need this? What happens if we don't do this? Is this really needed? Is this the best option for me? What are the risks? What happens if I do this? What are the risks of this happening? And then what are the risks of this happening to me? There might be a high risk. There might be some risk of things happening, but for certain people or certain groups of people, those risks might be very low. Are there other things that we can do that are simpler and safer? What happens if I don't do anything? Again, what are the risks? If I don't need this, what happens if I don't do anything? And then most importantly, what are the costs? And we know that sometimes, I'm sure, how many of us have been surprised by a cost of a test or some healthcare that we received, and there were some costs that we didn't know were going to happen. So asking about cost is something that is recommended. Now, I'll provide a link at the end to the Choosing Wisely group, because they've got a whole lot of lists of questions that people can ask in different contexts and around specific things. And I think this is just a really good starting point for questions that you can ask about anything that you might be referred to. So don't be afraid to ask questions. I see there's people here who are taking notes, either in notebooks or on their phones. Take your notes and bring your phones to your GPs and doctors' appointments. There are times and places where we're given a lot of information and we can't always take it in, so bring someone with you, take notes, it's really important. Doctors take notes to help with their memories later on, so we can take notes as well. And I wanted to also, let's start a conversation about reliable information, because I really believe the more information we know about our health, about our treatment options, about our diagnoses, not only does that give us more choices, because knowledge is power, but also it's better for the system, and it's better for those choices. So it's better for us in the long run. So where do we go? How do we get reliable information? And that big question, how reliable is Dr. Google? Now, I want to try something here. Oh, no, I'm going to come back to that. Okay. I typed in this question, who is, and I just use our initials, who is HCNSW for Health Consumers New South Wales? I typed it into Google. And what Google's doing at the moment is a couple of things. This is the answer that I got. So up the top here, it came up with, that's Health Consumers New South Wales, that's our website. This is a picture of me and the team. It's an old picture, but it's on our website. There's the address, we're in this building, so that's all right. And then what Google's doing now is that it's coming up, these immediate questions under here are things that Google's artificial intelligence, its AI, is throwing up, because it's thinking, well, okay, you've asked this question, and so I'm going to provide you some more information about this. And that information is not always correct, and in fact, this AI that Google's throwing up can be very, very wrong. And you can see here, it's linked this question about who is Susan Pearce. Well, I don't know if people know Susan Pearce. Susan's a lovely lady. She doesn't work for Health Consumers New South Wales. She's the Secretary of New South Wales Health, so the person who runs the Department of Health in New South Wales. Related to health, we've mentioned Susan on our website a couple of times, which is probably why she popped up here, but nothing to do with us. And then the next question it asked is, who is the head of health in New South Wales? Again, we don't run health services. We don't run health in New South Wales. And it said that, it said here, Dr. Kerry Chant is the head of health. Now, Kerry Chant, people probably remember Kerry from COVID, is the Chief Health Officer of New South Wales. It's a very, very important position, but Kerry's not the head of health in New South Wales. So here's an example of Google pulling together information in a way that it thinks or doesn't think, in a way that is based on its complicated algorithms and to come up with what it thinks are the answers that you want. And actually these answers are incorrect. So that's just about us at Health Consumers New South Wales. I think people need to be very wary of putting into Google, tell me about my diagnosis, tell me about my illness, and expecting that what you see on the front page is going to be correct, because it grabs information from everywhere, mushes it all together, and when it mushes it, it doesn't get it right. And mush is a very technical computer term. So what I want to do is to say that, so be wary of that, and remember anything that's been generated by artificial intelligence at the moment can be very wrong. And there's this great term, they call it hallucination. They say the artificial intelligence hallucinated. And so this is a Google hallucination, which I think is a great term because it's just wrong. But having said that, I will say that I really believe the internet is a patient's friend. The internet is a patient's friend when we get good information and when we know where to go. And I want to leave people with and let people know about this website called Health Direct. Now, Health Consumers New South Wales doesn't run Health Direct. It's a government-run website. It's not perfect, but it's very, very good. And you can see here the links to Health Direct is here, healthdirect.gov.au. And what I'm going to try and do now, yes, this is the Health Direct website. Now, I'm not going to go through this in detail, but I would really encourage you at home or at the library or at the SMSA library upstairs, have a look and have a play with Health Direct because it's got some really good information. It's got something here called a symptom checker, and you can go through, again, I won't go through it. It asks you if you're looking for you or someone else. It asks some information about you, your age and where you live and things like that, and then what are your symptoms. And at the end it's going to say, okay, this is serious, go and see a GP quick. or it's going to say, this is something, go and see a pharmacist in the next couple of days. It's not a diagnosis, but it's telling you what the best step is and who the best health professional is to connect up with. It's got this great medicines finder where you can have a look at a medicine that you're prescribed and get some more information about that. Now, we all know, when you buy your medicine and you've got that information sheet in it that's got really good information, and then you throw it out because you're tidying up, and then a couple of months later you think, where did that go? You can actually find a lot of those things on here. And the good thing is you can search by the brand name for the medicine, so that's the big name on the label, or actually by the active ingredient, the proper name of the drug, and it gives you all of that information. There's also health topics, and people can look up diagnoses, health conditions, and this website's put a lot of energy into bringing together up-to-date, best quality information about what's going on for people and giving people information about the conditions and your diagnoses. And while Dr. Google may hallucinate, and this won't have every condition ever, and it's not perfect, it's still very, very good. And I'd really recommend, if you want to find out information about health and healthcare, have a look at Health Direct. And the one other thing about health that Health Direct has is got this 24-hour number, because one of the things we know is that it can be difficult to find healthcare. We know getting into a GP is expensive and difficult, particularly if you're looking for a new GP. This 1-800 number, 1-800-022-222, is a 24-hour number. There are registered nurses who are there who people can talk to. If something's serious and out of hours that the nurses can't help you with there and then, they can connect you to a telehealth consultation, to a GP, and even through that you might be able to get an electronic script and things like that. So if you're having difficulty finding a GP, if you're having a health problem out of hours, I'd recommend this as a starting point as well. And I'm sure Dr. Kim's got some other suggestions and things to say about that. So Health Direct, great place to start, and it's also got a list of services that you might be able to find in your local area. So where do I find a physio near me? Where's my closest GPs? Those sort of things. It'll list the services, but unfortunately it can't guarantee that they're available. You can get into them, but you can find local services that are available. So this was all stuff I put on just in case the website didn't work, but it did. Now, the other thing I want to leave people with is this fantastic booklet that unfortunately isn't printed anymore. But it is available online, I know. We don't print it, it's not our booklet, but it's excellent. This is my last copy, and it is my copy that I use for my healthcare. And it's the top tips for safe healthcare. And actually, I started with the first two. Ask questions. You've got the right to ask questions. And this little booklet also talks about some other questions you can ask and tips for asking questions. Find out good information. Talked about where to go for good information. But the other things about understanding risks and benefits, have a list of all your medicines handy that you take with you. When you go to the GP may know the medicines that they've prescribed to you, but if you've had other medicines that have been prescribed in hospitals or by specialists, they're not always available to GPs. You hope they are, but not always. So if you keep that list, that's a way that we can know that you know what you're on, and you can talk to your GP about it. Talks about confirming the details of your operations beforehand. and 4 other things around if you're in hospital, some ideas about asking about your care before you leave, know your rights. We talked about, I started with those healthcare rights. Have a look at those. I think they're, as I said, the most important document in healthcare in Australia. Understand your rights around privacy. Your medical information is confidential, and you do have the right to ask to see a medical record wherever it's held. And you've also got the right to give feedback. Feedback about good things, things that happened well that you liked, but also recommendations where things could go better, and the right to make complaints when things go bad. And this booklet is available at this website. And I'll give all those websites at the end. So I said that I was going to speak very, very briefly about that idea of systems advocacy and how we can work together to make healthcare better. One thing you can do is join Health Consumers New South Wales and become an advocate for patient and carers. And through that we can work with health services and policymakers to make a difference, because they're hearing directly from what's important to people and what it's like to actually receive healthcare, what it's like to be at the other end of the needle. And of course you can make a donation to Health Consumers New South Wales. Donations are $2 and over, tax deductible. But that phrase that we've borrowed from the disability movement, nothing about us without us, is what we're all about. And while providing information and doing all we can to make our own healthcare better is important, collectively we can work to make healthcare better and fairer for everyone. And these are just the links to the resources that I mentioned today. So thank you all very much. I know we've been asked to hold questions till we have the panel discussion, and I'll invite whoever's doing this next bit to do whatever comes next. Thank you.
Thanks so much for that, Anthony, and that was a very informative talk and a very good segue into our panel. So just bear with us while we set up for that. Excellent. It's great to have you here joining us on the panel now as well. Dr. Loo, did you want to give a little bit of an introduction of yourself and your approach to GP practice as well?
Okay. So I graduated from Sydney University in 1989, and I've been working in general practice since 1993. And I represent the Royal Australian College of General Practice, which represents 40,000 general practitioners, and I'm also on the Council for the Australian Medical Association in New South Wales, and also a general practice leader in my local primary health network. So the way I see healthcare is not a healthcare system, it's a sickness system. So when you approach hospitals, you are unwell, you've fallen off a cliff. And really we need to, and the funding is for sickness, it's not for keeping people well. A very small amount of money is spent for preventative health. 7% of funding goes to general primary care. And the way I see, we need to actually keep people well and start off with preventative care. So the way I see the health system is that we need to have a patient-centred, team-based approach in the ideal world. We need to have our primary health networks communicating with our local health districts, so primary care with our hospital system. The bulk of the money that's spent in health is in the hospital system. So when I mean a patient-centred, team-based care, the patient is at the centre. I'm the general practitioner. Other members of my team where I work is the nurse. We've got our pharmacist. We have the allied health people. And I wish I had a social worker, because I do spend most of my time doing social work. So because we have so many, there's been a rise of what we call non-communicable diseases, which is the rise in chronic diseases. And I work in Western Sydney, where we have a significant number of my patients, almost 60 to 70%, have multiple chronic diseases. And what I tell my patients, I work with them as a team to do housekeeping. So when I say housekeeping, I mean having regular visits like every 2 or 3 months. So if someone with diabetes, hypertension, heart failure, I can practice high-value care, which means looking at how they're living, what they eat, whether they're sleeping properly, whether their energy is good, looking at what they're worried about, looking at the medical determinants for health. Do they feel safe in their home? Can they actually keep adequately warm during winter and cool during summer? How safe are they? Are they networked within the community, or do they live in isolation? Because we know that people who live in isolation are more at risk from everything. And to actually, with our practice nurse, I work in a very large practice, and we train general practitioners. So there is a system where they change every 6 months. We have one nurse who knows the patient, so there's continuity of care. And we have our pharmacists, because with medications, I mean, some of my patients are on 10 medications to help them stay well. And, medications can be complicated because you need to know when to take them, how to store them, whether you can take them in a more simple regimen, all at once or twice a day, not multiple times a day. So the pharmacist helps me with that. And my area of advocacy is to really look at ways that we can actually communicate with hospitals better. And so the advocacy has led to every time my patient ends up in any of the 3 hospitals, the feeding hospitals, which is Blacktown, Westmead and Mount Druitt, in my inbox comes their discharge summary when they're discharged from hospital. Because the gaps in care and when people die and when they leave hospital, and we don't know, the general practitioner does not know that they've left hospital. So continuity of care is critical. So, and the housekeeping you can do at home is also, we know that evidence is that if you are at home and you do 3 active things in a day, that can keep you cognitively and functionally better. So it's really I teach my patients to have the health literacy, and my team to actually understand what they consume, because there's so much disinformation around. And my patient showed me yesterday a fake AI video with one of the chief health officers rubbishing metformin, which is a drug that has been shown to improve health outcomes. So, information is going to come your way on algorithms that is not true. And so health literacy is so, so important. And so I work with my primary health network. We were in a leaders meeting last night to look at ways that we're advocating with our health department, health ministers, to improve the quality of care for patients. So it's patient-centred, team-based care where there's good communication at all levels. Because it is really hard, and I've been working now for 36 years. I've got patients I've seen for 30 years. And not everyone has that. And that's the same with the rest of the members of my team at where I work. So there is a large group of patients who don't necessarily have a good general practitioner, or actually have a general practitioner at all. And part of the government is trying to get, it's called My Medicare, if you heard of it, to link patients to the practice. And that's an important thing, because we know that people live longer if they have a general practitioner that they see on a regular basis. And we know, just in terms of primary care, we know from studies in Denmark, if primary care is supported, you need less hospitals.
Kim, you've given some really great points there around AI, continuity of care, and what good care looks like. I thought maybe, Anthony, we can bring you into the conversation here. How important is continuity of care when it comes to choosing a provider, a healthcare provider, and what can people do to make sure that the healthcare provider that they choose is the right fit for them?
Okay. Well, what have I done? Okay. Continuity of care is really important, and it's one of those jargon words and jargon terms that actually means how smooth is our journey through the healthcare system. And I think there's lots of people in this room who can attest from personal experience that that journey is not always very smooth. And it's those points when we move from one type of care to another where things can go wrong. So Kim's already talked about between the GP and the hospital. And if going into hospital isn't planned, then the GP may not necessarily know someone's in hospital. When you leave hospital, the information is not fed back to the GP, or you're not given a lot of good information about what you need to do to help your own care. Visiting specialists, whether they're in the public or private system, allied health, private providers, who else? Nursing homes. So it's when you move from one type of care to another that things can go wrong. So getting that right is really important. Some of those things are big systems things that the system has to do so that one part of the system talks better to another. But some of it's also the things that we can do, like asking about in hospital, what are the plans for when I leave? Who's preparing my discharge plan? What are the things I need to do? And what are the things that I need to make sure that my GP knows? So there's some things that we can do. Sometimes when we're in hospital and very sick, it's not the time when we can be having those conversations because we're very sick and we're concentrating on getting better. So that's really important. The other thing you asked was about choice of provider, and that's one of the things that I think is a bit of a myth in our system, that we have a lot of choice. We look for great GPs, and that's probably the area we have the most choice, but that really depends on where you live. If you live in an area where there's more than one GP or more than one GP practice. We know for people in smaller communities and smaller country towns, there isn't a lot of choice of GPs because that's who's around. And then actually being able to get in, particularly to a good GP, is very difficult because they are good GPs and people want to sort of be there. Our choice of specialist, in theory we have a choice and we can choose, but most of the time, because we're not experts in who the specialists are, we go on the recommendations of our GPs and who they've used. And when we need to go to hospital, most of the time, of course, it's the hospital that's closest to us or the one that we've been to before. So choice is an important idea, but I think really at the heart of it in the Australian healthcare system, we don't have as much choice as perhaps we could. And that's not necessarily a bad thing, and we do need to be informed about our healthcare providers. But if we can make everyone in the system better, then we're faced with better choices, whether it's our choice or our GP's choice or whoever it is.
Kim, did you want to add anything to that?
Yeah, I'm lucky in a space that our practice is well resourced in terms of information, but not everyone has that. And look, I've been a health consumer as well with my father, going through the hospital system, and I was glad I was a doctor when he went through Westmead Hospital because I was his advocate. And my son when he went through the Children's Hospital. It was good that I understood the system. But not everyone has a doctor as their daughter or their mum. And it really navigating through the hospital system and knowing what to ask about and who to ask can be diabolical unless you know the system. And and that's why we need advocates when people actually land in hospital.
Absolutely, and I think what you've both really described are complex ecosystems in health, be it in the general practice setting, be it in allied health, or even the hospital setting itself is a very complex network.
And one of the things that's really interesting and I think terrible about healthcare is in other types of care, so in aged care and in disability care, there are places where people can go to get that individual advocacy from a professional, from somebody who knows the aged care system and who can provide some advice, whether it's general advice or advice in your specific area. Same for disability services. There are disability advocates who can help people through that complex system. They're not perfect, there's not enough of them. But in healthcare, there's precious few places you can go to find out who can be an advocate for you, as an individual going through the system. I would love if Health Consumers New South Wales, for example, could do that, but we can't. We just don't have the capacity or the resources to do that. And there's no one in New South Wales who does. And I think, of course, we should do all that we can to find out more about the system, to find out more about our treatments and the treatments and illness of people we're caring for. That's going to make a big difference. But where we go to get that information that's specific to us, that's a real gap, and it's something we really need. Someone who can work with you to provide you the information that you need when you need it. And that idea of health literacy is really good because we can build up our own literacy and knowledge about health and our own health. But one of the things we need to be careful about is that the idea of health literacy is not just about us. The problem is, we're just not smart enough or know enough about health. And I know that's not what you mean. And the really good health services are seeing health literacy as two things. One is the knowledge that patients have, and they're starting to ask ourselves, are we a health literate organisation? Are we providing the information to people when they need it, in a way that they need it, and in a way that they understand? So I'm agreeing with everything that Kim says, and it's fantastic that there are practices like yours out there. We need more, and we need more hospitals that are doing that. But that idea that, and we all need help in building up our health literacy because it is such a complex system. Health's so complex, our treatments are getting more complex, which is good because we're living longer. But yeah, we need to be looking for ways to get more health advocates in the system who can help us. Completely
agree. Because it is, and my patients tell me that they're lucky because in a way I'm their advocate through the health system, and so is every single doctor, and our nurse and our pharmacists and our allied health are their health advocates. We know the ecosystem of healthcare within Western Sydney, and we've got health pathways as well, which is another pathway that if our new so it's a pathway for our new doctors within our practice to look at the pathways that are existing and the information pathways. So we are advocating within the college, within our primary health networks, to improve the system. So if health advocates outside the health system advocate, that's how you change the system. Because at the moment, since because doing medicine for 36 years now, I kind of see all the faults in the system and where patients aren't put in the centre and corporates are, like every other area, are dominating, and that's not necessarily for the quality of care. And to look at the funding model for health, because it's not it is at the moment federally focused on access and and how cheap the system is in terms of bulk billing everyone and access. Those are the two important things. They're not focusing on the quality of care. And we need to kind of focus on everything. But that's why the really a teams-based approach is so important, because we have a 10% shortfall of general practitioners within New South Wales. To actually expand the team, so it's not just the general practitioner, it's the general practice nurse and the other team members. So it's looking at the teams-based care that we're looking at. And really the acute care clinics are being funded. Don't look at that. That's looking at the sickness. We need to look at a health model.
You've raised something really interesting in what you're saying, Kim, around the doctor or the medical professional being the advocate for the patient. I sometimes see and I sometimes feel that, you go into a GP appointment, you've got 5 minutes, you don't want to take too much of the doctor's time up because the doctor's a busy person. How should patients feel about tapping into their medical professionals as being advocates, and how can you actually do that? What's the approach you should take?
Okay, so within our West, we actually put practices in 6 classes. So we're actually looking at this. And so our practice, so the top class is general practices that do what I've said or trying to do what I've said. Then you have the transactional practices. So a lot of the when I say transactional, like you go there for a script and that's all they look at. So they're basically the way the Medicare model is being funded, it's funding, like the benefits are to the transactional practices. But we're trying to bring those practices along, if we can, to being the type of practice where the patient is the centre of and it's team-based. So we're trying to educate and drag those practices along. But it's a lot of work when people are looking at access, and access is super important because you want to be able to access a doctor when you're sick, okay? But is to try to look at the model where we can actually have a health model. Look at the acute as well, but at the moment, because we don't actually fund and value high quality care, the number of people who fall off the cliff and end up in hospital is higher. And we can look at other models of care in Denmark where the population is kept healthier so they don't end up having a large acute service. It's how you view it. And, in an ideal world, I would love Denmark's model, but that's not where it is at the moment in Australia. But, we have a bunch of doctors who actually see that we need to improve quality care, but look at ways of improving access by having the teams-based approach.
Yeah, absolutely. So, Anthony, do you have any tips for people on how they can approach their medical professionals to become advocates for them, for their journey, for their health journey? How do you approach that?
That's a very big question, isn't it? And it depends on the person, the patient. It depends on the doctor. Some doctors might be very good doctors, but that's not what they want to do or are able to do. Some people don't know that that's an option. So the first thing, of course, is asking. And that idea about the medical team is really important. And what I think the first thing to do and the thing to ask about is to say to your doctor, how do I become part of the team that's looking after my care? How am I part of this team? And ideally, we need to think about that idea of patient-centred care is really important. But there's a danger to patient-centred care when we say, well, the patient, of course the patient's in the centre, the patient's the person in the bed, that we're all doing all these things too. And I know that's not what you mean. But I know that there are other parts of the health system who that's what they think patient-centred care is. We have the patient in the middle and we're doing all these things to the patient, when actually we want to have patient patient-centred care that's sort of turning into patient-directed care. So we're not doing things to people, we're doing things with people. So asking about, how do I become part of this team? And some of the direction might be, actually, doctor, what are you going to do? I'm quite happy for you to take charge of this. And that might be the way you want to work with your doctor all the time. It might be the way you want to work sometimes with your doctor because your health goes up and down. But the first thing I would ask is to use that idea of team-based care and say to your doctor, where am I in this team? Am I part of the team? And directly, and hopefully, am I leading this team? And that move from, and we're seeing this with good doctors, the move from asking people, what's the matter with you, to what matters to you. And if you can convey to your doctor and your team what's important to you, then hopefully they can work with you to achieve those things. And some other aspects of your care will be determined by that. So, yeah.
Yeah, absolutely. So, Kim, if patients are feeling like they're not being heard, so, they've gone through this process and they're feeling like they're not being heard or their concerns aren't being taken seriously, what's the next step from there? When is the right time to do something?
Okay, because when I explain something to my patients, I'll ask them, does that make sense to you? And it's really important that I teach registrars to say that, because sometimes we can explain things. That's why I use a lot of analogies. That's when I talk about housekeeping, coming in regularly if you've got a chronic disease. I always use the car analogy. Your car needs to be serviced, and so do you. And it's really teaching active listening. Active listening is so important in general practice. And also teaching our students that, because, being a doctor is like being a detective, because we have the knowledge of the system and asking questions to look at the history and not to see someone walking in and prejudge what they have. Because in a way, general practice, and I've been doing general practice for so long and I still love my job, because everything's different every single day, even with patients I've been seeing for 30 years. And that's why continuity of care is so important, and building a relationship is so important. So it's really teaching our medical students, and we do see medical students. We have medical students in our practice.
Absolutely. Anthony, did you want to add anything to that?
I think that's amazing, and that idea about talking to patients about what they understood the conversation was about is really important. I think for patients, the thing to remember is that when I talked about that Charter of Healthcare Rights, one of the things in the Charter is that we have the right to give feedback and we have the right to ask questions. And I'll just read out what it says in the Charter, that we have the right to give feedback, to provide feedback or make a complaint without affecting the way that I am treated, to have my concerns addressed in a transparent and timely way, and to share my experiences and participate to improve the quality of care and health services. So when things don't go well, and for most of us, most of the time they do go well, but when things don't go well, when we feel we've been treated badly, or when we know we've been treated badly, we have the right to, first of all, give feedback to the person who's done that to us. And even though we've got the right to do it, I know that can be difficult, because if it's happened in a hospital or it's happened from your GP, this is somebody who you need to have an ongoing relationship with. if it's a specialist who's sort of been looking after you for a long time. So I know that can be difficult. There are two important groups that we can make official complaints to. One's the Healthcare Complaints Commission, and the other is AHPRA, the Australian Health Professionals Registration Authority. Okay. And they're important groups to know about, and I can provide the links so that they're online. And I would say to people, if something bad happens to you, please let people know. And there's two reasons for that to happen. One is it might help resolve the issue that you're going through. It may not. It may not. If it doesn't help resolve the issue, then it's alerted the system that something's gone wrong. And by working through it, hopefully they can make corrections so it doesn't happen to other people. Now, I don't want to pretend that the complaint system is easy. We have a very complicated health system, as we all know. We have an equally complicated complaint system. And that's not a good thing. But making a complaint, getting things onto the notice of the system, hopefully helping then work through it to make things better, is really important. And even if something's happened that's serious but it's been resolved, the complaints process is a way to make sure that the system knows that it's happened and it's recorded in all that official data stuff. So first step, of course, is talking to your treating doctor and your treating health team. But if something terrible happens or if you're not happy with that, there's the official complaint system.
Yeah, telling your doctor is really, really important, okay? I know within most practices, you can directly complain to the practice manager, because having complaints helps us look at our system. If we don't know something is happening, that people are unhappy about it, we don't know about it. You don't know what you don't know. So complaints are really important.
Excellent. I might open up to the audience now for any questions people might have. Excellent. A question down the front here, and then we'll go to the question at the back.
Thank you. I'm just wondering which branch of the healthcare administers the pharmaceutical benefit scheme, please. I find it very difficult to understand.
It is very difficult to understand, and you're not alone. And I've been working in Health Consumers New South Wales for nearly 11 years, and I don't understand. So it is complex. And the pharmaceutical benefit scheme is something that's regulated by the Commonwealth. And it's my understanding that the TGA, the Therapeutic Goods Administration, is the group that's got responsibility for that. One of the things that's difficult in the system, and I talked before about systems advocacy, so Health Consumers New South Wales is all about trying to make the system better. So the clue's in our name about New South Wales that we work primarily in what's happening in New South Wales and the responsibility of the New South Wales government. So state and territory governments are the ones that provide the public health system, so the public hospitals, community health centres, the range of sort of public health systems, services that we use, all come from the state and territory governments. And then some of those big picture important things and payments and policies are set by the Commonwealth. So the pharmaceutical benefits scheme. The Commonwealth is a program through Medicare that pays GPs. So, and that's part of where we get this sort of fragmented care, and where care becomes that continuity of care becomes difficult because we have the Commonwealth who funds GPs directly through Medicare. We have the states that fund hospitals. We have the Commonwealth that sets important policies and things like the Pharmaceutical Benefits Scheme. And then we have groups like us and CODA who are working at different levels. And I don't like to say this, but we're trapped in their silos. So at New South Wales, we focus on New South Wales stuff. I can tell you all sorts of things about the New South Wales system and how it works. I don't know a lot about the Commonwealth system because our national organisation, which is called the Consumer Health Forum, is the one that works at that level. And so I'd encourage you to have a look at the Consumer Health Forum's website as well. So it's really unnecessarily complicated, and that's part of the reason why there's a lot of people fall through the cracks, because there's a lot of cracks.
Yep, and also like our hospital clinics are also funded federally.
Yeah.
So it's a mix. It's a very mixed system, and it's really murky in terms of the funding, in terms of how state and federal contributes to the health system in New South Wales.
Absolutely. So we'll have one question here, and then we've got a question at the back.
One of the difficulties with feedback, particularly if it's negative feedback, is not only the huge knowledge imbalance between the patient and the doctor, or the patient and the hospital, but the huge power imbalance as well. And I have a very good GP, but it's partly that I'm bulk billed, and I'm so grateful for that, but I also feel I must not take up too much of his time because he's not getting very much money for seeing me. In fact, I'm not sure whether the bulk billing is based on a 6-minute consultation. And the problem is, if you have a chronic disease, which is incurable and progressive, this fast-through medicine does not work for you. And so my doctor, who is extremely knowledgeable and well-intentioned, gives the very good basics. I'm absolutely confident in his diagnoses and so on. But one of the things that they could do is when you come for, say, for example, you've been diagnosed with arthritis or diabetes, the doctors should have an information sheet saying this is the organisation, Arthritis New South Wales or Arthritis Australia or diabetes. That's where the patient can find many of their questions being answered. That's where they can get support. That's where they can get booklets. But if I've been left to sort all that out and explore all that for myself. And sometimes when you talk about the health team, there is no health team in the GP surgery. There is a bunch of GPs and their admin staff. And only by accident, for example, if you wanted to get some hydrotherapy, for example, for the arthritis, you can stumble upon that by accident, and he can say, oh, I can see because you want to help yourself, here's the information. GPs don't understand that a lot of patients are dying to help themselves, but they need to be given the starting point. They need to be given the information. And finally, this whole business of the patient as their own doctor in some ways breaks down in the final stages of life, which is terrifying, and we're not having an advocate and being on your own and just being told, here's $25,000, now you go away and you die on your own terms. It's terrifying.
You can't look after someone with chronic disease in 6 minutes. It's too difficult, even if the patient has a high health literacy. And I suppose I've never practiced the 6-minute medicine. I've been really very fortunate to work in practices that allowed them to spend time adequately, to spend with a patient. And that's the limitation. We need to move people who are working in transactional practices into team-based care if I don't have the time, my nurse spends the time doing it. Because if I give a patient a fact sheet, I'll go through it with my patient. A lot of fact sheets are now written with a 5th or 6th grader reading level, because this is looked at. Sydney University has a department that looks at writing health fact sheets at different literacy levels. Because you can't have a universal fact sheet that's not understood by the bulk of people. And yes,
So,
I would never actually leave a patient to search. It is so hard for your doctor, but this shows why a teams-based approach is so important.
and I'm sorry that I don't have an answer for you. And I know that situation a lot of people are in. So there's a couple of things that might be helpful. The first thing with the system at the moment is when you make a booking to ask for a longer consultation, because as your health needs get more complex, a GP will need to spend more time with you, and the GP will be reimbursed more for a longer consultation. It's probably still not enough, but it sounds like that's a genuine...
So twice a year there is what we call a health care plan and teams care plan, where we are actually adequately reimbursed to spend up to an hour with you, okay? So it's to do the housekeeping. So you do have a long consult maybe twice a year to look comprehensively at everything. And there is the billing, it's called 721, 723, where that can be done. So that every other visit is the maintenance, and you have 2 big services per year. You might need to ask your GP about that.
So just quickly, Kim, what's the name of that consult?
It's a GP management care plan and team management care plan.
Okay, great.
And the other thing that I'm hopeful might make a difference, but I think it's only going to make a modest difference, is what Kim talked about before, and that's the introduction of this new My Medicare. And so with My Medicare, as I understand it, and the Commonwealth have done a terrible job about letting patients really know what this means, by registering with a practice, then that practice, as I understand it, will get some additional payments that should allow them to do some other work. So if they've got a big number of patients who have diabetes or have a particular condition, they can get a diabetes educator, or they can do more work around the planning or the connection stuff. So still don't know a lot about it, but that's one way. And the other thing, I think that strategy, I didn't mention this, but another good strategy to find good information is to connect with some of the consumer organisations that are out there and some of the patient groups. You mentioned Diabetes New South Wales. There's a whole range of groups who are there who work with people with specific conditions. So whether it's the Cancer Council or whether it's Cancer Voices for people who are living with cancer or have a cancer diagnosis. There's patient groups for people who have mental health diagnoses. We have 50 organisations who are our members, and they're all working with different groups. So that's another good way to get information and good quality information. One of the things that I really hoped when we first heard about the health pathways, which was a good idea, so a doctor says, okay, this is a diagnosis, and then they get up all the information about this is the up-to-date treatment plan, this is what we do. We were hoping that something like that would also say, and here's a link to the diabetes educator in your area, here's a link to Asthma Australia, here's a link to the walking group that's happening, or the men's shed, or something. And the pathways have been very good at getting that clinical information, so you know your doctor's giving you the good, up-to-date clinical care that you need, But that social information, that other support that's equally as important for your well-being, and I would say is a really important part of preventative healthcare, health pathways haven't done. So we had this great system that hasn't lived up to all that it could do yet. So back to us then to find that information. And I would say look for those groups that are out there that are working with patients with the same diagnosis that you have. That is another excellent way, not just to get support, but then to talk to someone who's been through what you have been through and is going through what you're going through. Yeah. I know that doesn't answer all those questions, and that terrible situation when people are very sick or at the end of life, and it's put back onto them to manage their care is just awful's too nice a word. It's a vile sort of system that doesn't understand people and hasn't put a patient and what they're going through at the centre of it. And to sound like a broken record, that's why it's really important that we're involved in designing what these systems look like. Because if patients and families who had gone through that were involved in designing this, we'd never have that system.
And say, I work with Western Sydney Primary Health Network, and we have so many NGOs who work in this area, but it's important for us to, and this is another area of advocacy, to improve the systems so that it's accessible and people know about it. And with, things change suddenly in New South Wales Health, because I will also do palliative care, and it's changed from silver chain now to the local health districts managing it. Suddenly, last week. So, it's really for us to be aware. This is why it's diabolical for me to navigate the system as well, because systems change. And it's not like in COVID where we heard about the systems change on social media. But now the systems change. It's still the pathways to us knowing is still slightly opaque to the reason why it changed. So that's why we have our group within our primary health network to look at ways to inform. So we are working within the health system to try to improve the access to information as well.
That's excellent to hear, Kim. That's really great work. I think we had just at the very back row another question, and then we'll come over here and then over here and here. So we'll have those 4 last questions, so starting at the back.
Yeah, just a big thank you very much for reminding us that it is our right and responsibility to understand that these services are not a favour that we are receiving. People are getting paid to provide this service. And when patients come and complain about the service and you quickly remind them that there is a form or that there is a number that they can complain, they'll simply say, oh no, just leave it. So that leave it has normalized the system that it's not allowing us to do and have the voice that we need to have. So we do need to take responsibility for not making that extra step to complain. There are forms, there are telephone numbers, there are people that we can complain, but unfortunately, it is very easy to complain to the person that is not able to do anything, rather than complete a form and ensure that that record remains and we no longer, normalize the system that we are currently facing.
Agree about the complainer.
Yeah. Absolutely. There's some really great points that you've made in there. It is important to give yourself a voice and make sure that you are able to and you feel comfortable to follow through and talk more about the issues that you're facing, because we can't improve the system without that. So thank you very much for that. Our next question.
I'm interested in how you begin the decision making between pursuing treatment in private healthcare or public healthcare. Okay, money aside, let me just give you a brief scenario. Older person arrives in small coastal community, has to travel to a major hospital or wherever for surgery for a hip replacement. The person they see is the local locum who
is the only GP they can see as a locum who doesn't know the system. So they're going to have to travel to a bigger town for a hip replacement. How do you begin to make the decision about pursuing public health care or private health care?
It is a diabolical situation because there are less health services within country areas. And this is why, how do you have the system where it's really hard to pursue a healthcare in the local area when there doesn't exist, when you don't have a public system within your local health network to have a hip replacement in that area? How do you empower the patient and the doctor to understand the closest system?
So
it is really difficult, even within where I work that's well resourced. And I'm just lucky I know the system because I've grown up with the system. But we're looking at ways. It is so hard because we're kind of advocating within the system and understanding that the pitfalls of the system where it's just absent in areas.
Yeah. And so, so,
yep. So it's really up to the locum to actually see what is the local. If the patient is the public in the public system, maybe Gosford is the closest hospital.
So can I? Yeah.
Sorry. I'll let, yeah, okay.
So that is again a really awful situation a lot of people find themselves in, and there's two things I'd say. One is it's very hard for that locum to find that information because they're there. They might be a locum there one day, somewhere else the next day. It's great that they're there, but they don't have all that connection. And that's why I really believe that someone who can be a professional advocate or professional navigator is somebody who, if there's somebody in that health system, the local health system, who knows the what's available and the different services, a locum doesn't need to make all those connections, it just has to connect to that person who has the connections. That person doesn't exist, unfortunately, as a job. The other thing that I would say, and we know this about health, most of the time we think you get what you pay for, and if you pay more money you get a better quality service. That's not always true in health, and we can pay a lot for private services and we don't always get, and private services don't always deliver better health outcomes. So one of, and it's random, I can't tell you which ones are good and which ones are bad just off the top of my head. But one thing that is useful, you mentioned hip replacement, knee replacement. Okay. So what is published on the New South Wales Health website, which is a diabolical website, there are the outcomes about what's happening in different public hospitals. So you could, in different hospitals where they have the information. So you could find out, if you have to travel, where are places that have the least rates of complications or the least number of days that people need to spend in hospital after their operations. And so these things are published on the Bureau of Health Information. I can give you the details afterwards. One of the reasons why I didn't mention that in our talk is because of that idea of choice. If you know that, and I'm making this up, that the Tamworth Hospital has the best outcomes in a particular area and you're based in Albury, that's not a lot of help to you. But you can sort of, if you have to travel, it might give you some information about sort of some of the other places around.
So
there you go.
So one more thing is that within our system, within Best Practice, which is the system I use, you have access. So New South Wales government has access. You can see on HealthLink, there's clinics that are available in the local hospitals. So that registrar you're seeing will have access to the HealthLink communication or hospital email, because hospitals are now transitioning away from fax machines, and what's happening is either through HealthLink or an email for the department. So that registrar would actually have either of those two things for the local hospital. Now, the HIP registry was started a few years back when some hip replacements were actually causing harm and to the patient. So a registry's been set up for what are the best appliances. Ideally, what we should have is rating systems for specialists or hospitals, so we know how many post-operative infections someone has. So to have a coding system or a star system, which would be ideal, but we've run this past for specialist friends and no one wants it. So then it's a matter, and I've got a couple of my patients who are clinical coders for public and private hospital systems, and they know the outcomes of certain operations for certain doctors. But, that will never be published. So then unfortunately, it's up to almost the individual GP. Like within our practice, we have a whole bank of specialists we refer to, and we put rating systems next to each name. But that's just our internal, what we internally do.
Yeah, absolutely. I'm not an expert, but I'm going to put my 2 cents in here as well. So my mother recently went through ovarian cancer. My father had a brain tumour, and I've been using the public hospitals for the birth of my 2 daughters. And the way we approached it was to really look around for the practitioner that was going to meet our needs and was in the area that we could travel to. And once we found the practitioner that was the right one for us, and this is coming from a place of having private health insurance as well, so that choice was there for us. Once we knew who the practitioner was, looked at their reviews, had a deep look into their websites. For me, actually, their websites gave a really good tone, and looking at their experience, how long they'd been doing what they were doing, and if they'd sort of had a subspecialty into what they were doing, or if they had a particular area of interest that sort of was the right area of interest for us. So not just, a gynecologist, but a gynecologist that was really particularly interested in the particular type of cancer. That really, I think, was a great way for us to narrow down who we were going to see. And once we decided on that was a question of, do they have a public waiting list? Do they not have a public waiting list? And what happens from there? So our last 2 questions, one with Pete here, and then the next one across there. And a very special mention to Pete. Pete is a long-time member of CODA New South Wales and was the Director of Nursing at one of the hospitals before he retired. So welcome, Pete.
Thanks very much. Very quickly, couple of experiences that I think are relevant. I spent 4 decades working in public hospitals in New South Wales, and each of those hospitals had its peak committee that looked after patient care. It was variously called the Clinical Care Committee or the Patient Care Committee. And I think for the first couple of decades I worked on those committees and sat on those committees, there was no patient representative, which struck me as most unusual and points to your comment about how health systems need to shift to put patients more at the centre of design and operation. The other experience that is relevant for me was a personal one in terms of having lived most of my life in the Blue Mountains. we've had different relationships with general practitioners, and I think the nature of general practice changed a fair bit. We had the same general practitioner for 2 or 3 decades. Ian delivered the children and looked after us splendidly for many years, and then we retired and we moved up the coast, so clearly it wasn't possible to continue to see him. We saw another doctor, and Ian wrote him a letter about our histories and gave him that information, and we set up a relationship. But as we age, we find that the doctors that we've had were outliving both their careers and their lifetimes. And so the challenge has been for us to maintain the continuity of care, which you've described as so important. Medicine has become more corporate. There aren't as many, particularly in regional and rural areas, there aren't as many independent GP practitioners as once was the case. And but there is improvement in the works. I note that since the GP we started with on the coast retired, I'd gone to a couple of the corporate clinics. I now find that they're happy to identify the interests that their doctors have along the lines that that Gail has outlined. I think it's important that patients, particularly in those settings, but generally become more assertive about their health care, become more determined to be part of a team, as you've described it. Team medicine is great, and I think that enables GPs to work more effectively. But I think there's a responsibility for each of us to play a part in our own career, in our own care, to be assertive. I find now that it's not good to be too stoic. Once in a while, I think you should ask for a long appointment, go through your history, look at the sorts of interests that the GPs have. The clinic that I work with actually publishes the special areas of interest of its practitioners, and I think that's a really good move. But as I said, one of the doctors I saw went off to train in a specialty, so vanished into the ether. I've now established another relationship with a doc and said, look, are you going to be around? Because I really want not to be seeing various people all the time. I think personal responsibility is a really important thing. I think systems are moving, both in hospitals and GP clinics, to bring patients more into the role, but I think at the end of the day, it's our body, it's our health, and we've got to stand up and take some responsibility for it.
Very well made points. Thank you, Pete. And that's coming from some deep experience there. So thank you for sharing that, Pete. Last question over here.
Thank you. It's been a very interesting discussion. Dr. Kim, I would say that the practice you have is gold standard, and it's been very privileged to hear it. However, from my experience, and I would think from 90% of that room, that's dreamland. It's not our reality of where we are. So there's a couple of comments. I'd love you to do more advocating yourself to have the GPs educated to communicate with their clients in their practices. And I'm also speaking in respect as a regional person of having experience in a regional GP. With my hospital experience, I did put a complaint into the hospital, which was, and this is 12 years ago, which was handled beautifully. In my own GP practice, I became dissatisfied with my current one, and I navigated to another GP. But no way would I have put that complaint to the manager, because it is a good practice, and I did not want to jeopardise my treatment. But when you talk to the ladies over a cup of coffee, you hear who's complained about and who goes. So that's the reality of a GP practice, and I know it would be classified good. So the question also, I've found with my own treatment, the medical was fantastic, but the emotional support wasn't there. And what the lady here in the pink suggested, that a GP actually gives some information about arthritis or whatever, that encourages the person to take action. And I do advocate in my area for cancer care. And I know from the... And I have made a brochure of support services, but the GPs don't hand it out. They're so busy. They all say this is good, but they don't hand it out, which means they don't encourage the person to advocate for themselves, to pick up the phone. It sounds so simple, but they don't do it. And I really take comment to the healthy pathways. That's all the medical best practice. That's theory. But the reality of what happens in a practice is totally different. So what I'd like to see is more that connection from the medical practice to the emotional support so the person can move on. I'm sorry, it's my statement. I don't know what my question is. But no, what I do advocate is to think about how GPs can be more interactive for the patient to take action, and please do something to support regional areas. And because the ability and support there is so limited, and it seems it's always the bottom of the line. Even when New South Wales government did big regional research and how appalling it was, the change is so minimal.
That's exactly right. There's a lot of good points that you've raised there. Kim, did you want to have...
So we know there's a 10% shortfall of general practice within New South Wales. So this has been advocated through my college, and so there's now more funding because all the places were taken up in general practice because there were less people choosing general practice to start off with. Now the federal government has put more money into training general practitioners. But, you know, health is, in a way, everyone's responsibility. And I'm all into village building, as in, like, it takes a village to care for our community. And the other thing we've been advocating for is to have social infrastructure around general practices. Yeah. I am in the very lucky place where I've got the community centre behind me, the community garden, men's shed, local pools. And advocating at a built environment level, because it's not happening, is that social infrastructures are built into new communities. This is all long-term advocacy, because all this is looking, how can we build so that people don't fry in their houses, because it's going to get hotter in the future, and looking at the system, because every single decision from every single department in government should be placing health at the focus. So if we build this way, if we build transport this way, how is the community impacted? So this is even a broader systems advocacy, because we know that over the years there's public health changes like immunisations and approaches through public campaigns that have improved the overall health of the community. So I know this is big picture, but that advocacy is really important. And there is advocacy in terms of knowing the gaps in healthcare, and the Australian Medical Association is working hard in this area with the federal government as well. So all our organisations see the gaps, and we are advocating on behalf of our patients.
Last comment, Sam?
Yeah, no, firstly, totally agree with that. And if you look at, there's some areas of planning outside health, and I think urban planning is a good example, where they're actually designing, like it's almost as if they're designing poor health into what we're building. And that idea about the co-location of GP practices with other services is super. And really, really important, because it's what happens at the local area that's going to make the difference. That point about communication is so crucial. The vast majority of complaints that end up being investigated about doctors aren't because they've done something terribly clinically. Of course, that does happen. But it's about poor communication, people not understanding what was happening, those sort of things. One of the things, and it's very modest and it'll take a while to work through the system, that I'm really excited about is universities are now involving patients and community members in the design of what they're teaching. So they're hearing from us about the importance of communication. And the doctors have good clinical knowledge is assumed, and what the universities are very good at instilling, but they're now starting to hear from us directly about communication's important, and when we talk about communication, this is what we mean, this is what empathetic, active listening looks like. So it's going to be a while for that to filter through, but again, the involvement of people in designing the change, I think, is crucial.
Excellent. Thank you for that, Anthony. That brings us to the end of our panel discussion. If everyone could join me in thanking Dr. Kim Loo and Dr. Anthony Brown for being here with us today.